Hello, this is Chris Frigno. This video will discuss all three compartments of the leg being all that is distal to the knee joint. So we have the anterior, lateral, and posterior compartments as well as the foot anatomy. This series will be broken up into two parts. This first of two parts, we will discuss the anterior and the lateral compartments of the leg as well as the dorsum of the foot. In the second part, we will discuss the posterior leg and the plantar surface of the foot. We generally characterize ankle movements in two planes, the sagittal plane and the frontal plane. In the sagittal plane, the ankle can dorsiflex, or where you pull the dorsum of the foot up towards the shin bone, or plantar flex, where you put the plantar surface of the foot down towards the floor. Here in this picture, this is a picture of my 13-year-old daughter in Venice. This is St. Mark's Square, and she's plantar flexing here on her right limb and plantar flexing on the left. So she's doing a little on point in the middle of Venice, which I thought was pretty cool. In the frontal plane, one can either evert or invert. Here's a neutral foot. Everting is when the sole of the foot is turned outward. Inverting is when the sole of the foot is turned inward. In this image, this individual is inverting on both the left and the right foot. The leg osteology is rather straightforward, a warm-up of sorts for the foot. To review, the tibia has a medial and a lateral condyle. The top of those make up the tibial plateau. On the medial side, there's an attachment for the three tendons that make up the pes and serinus. On the lateral side, there's an attachment for the iliotibial band in this region. That area is called Gerdy's tubercle. The head of the fibula is where the biceps femoris attaches, as well as the lateral collateral ligament. And this is a key landmark for where the common fibular nerve courses. The head of the fibula tapers down into the shaft of the fibula. This taper region right here is called the neck. Anytime you have a head labeled on a bone, the tapered area is called the neck. The tibial tuberosity is the site of attachment for the patellar ligament, which is attached to the patella, which increases the mechanical advantage of the pull of the quadriceps muscle. As the tibia and fibula descend down, they're connected via a very robust interosseous membrane. The tibia has what's called the tibial crest. You can palpate this on the front of your shin bone. It's a very sharp ridge on the tibia. Thus, the anterior compartment will be lateral to that tibial crest. The distal tibia flares out three-dimensionally and medially sends off its medial malleolus. This is very palpable in the medial aspect of the ankle. Similarly, the fibula descends and flares out laterally as a bony projection called the lateral malleolus. These malleoli serve several functions. One, they give a robust attachment point for several ligaments. The malleoli also serve as functional pulleys for muscles and other structures that descend from the leg into the foot. In the case of the medial malleolus, structures that pass through the tarsal tunnel, which is posterior to this medial malleolus in this region, will course around the medial malleolus. And on the lateral side, the muscles in the lateral compartment will course posterior to that lateral malleolus. This slide is also a review from the joints of the ankle. However, I'll touch on just a few key structures. Again, we'll see the tarsal tunnel up in this region, posterior to where the medial malleolus would reside, just medial to the talus bone to which it articulates. We also see a couple other bony landmarks which the extrinsic muscles of the foot will attach to. In the anterior compartment, we'll see muscles attaching to the medial cuneiform and the base of the first metatarsal. In the lateral compartment, we'll see muscles attached to the tuberosity, this jutting of bone here off the base of the fifth metatarsal. We'll also see a muscle that descends down through this groove formed by the cuboid and this tuberosity. There are three compartments of the leg and each are innervated by a single nerve. Here's a cross section of the leg, roughly at the mid portion of the leg. Here in the yellow dotted region is the anterior compartment, and here we can see a summary of that anterior compartment. Here we see the lateral compartment, and here's a summary of the lateral compartment. And then you can see how large and vast the posterior compartment is in comparison to this anterior and lateral compartment. Again, today we'll be talking about the anterior and lateral compartments, and in the next video, as part of the series on the leg proper, we'll look at the posterior compartment. So again, here we see the anterior compartment just lateral to the tibial crest, which is this ridge of bone here that we can palpate anteriorly on our shin. We can see three muscles. You can see a tibialis anterior muscle, a extensor digitorum muscle, and a deep extensor hallucis longus muscle. Deep to these three muscles is the neurovascular bundle, the deep fibular nerve, and the anterior tibial artery and vein. Laterally, we can see the two muscles in the lateral compartment, but note that there is a fibula here, but there is no artery existing in this compartment. So we'll see that the artery actually descends in the posterior compartment, but like the posterior thigh, where there were perforating branches, we'll see perforating branches from a fibular artery that goes into this lateral compartment. We saw a robust layer of deep fascia in the thigh called the fascia lata. Similarly, in the leg, we see a deep layer of fascia called the crural fascia. Crural, or crura, meaning leg. Surrounding the leg is this crural fascia, and of course it has these indwellings of intermuscular septa that help to divide each of the three compartments, along with the bones. Once again, there are three main muscles in the anterior compartment, with a fourth being variably present. The tendons of these muscles cross the talocrural joint and are held in place by the extensor retinaculum that circumferentially wraps the ankle, thus preventing bowstringing of these tendons. If you palpate the anterior crest of the tibia, the tibialis anterior is that bulk just lateral. These muscles are extrinsic muscles of the foot. This means that they originate outside the foot, in this case in the leg, but insert onto the foot bones and therefore control the foot. This slide discusses the specifics of each of these muscles in the anterior compartment and mostly reiterates the text in your notes. The most prominent muscle of the anterior compartment is the tibialis anterior, which attaches from the lateral proximal tibia and interosseous membrane and descends down to attach onto the medial cuneiform and the base of the first metatarsal. In addition to dorsiflexing the ankle, because it crosses the ankle over here on the medial side, it can assist with inverting the foot, or foot inversion. The next muscle we encounter from superficial to deep is the extensor digitorum longus. It originates from the proximal lateral tibia, interosseous membrane, as well as the fibula, and descends down to attach onto the distal phalanxes, the dorsum of those distal phalanxes. Therefore, it crosses the ankle joint, crosses the metatarsal phalangeal joints. It can dorsiflex here at the ankle, or at least assist the tibialis anterior with that, as well as dorsiflex or extend the MTP joints, or the metatarsal phalangeal joints, numbers 2 through 5. Under the partial cover of extensor digitorum longus as well as the tibialis anterior, we can find the extensor hallucis longus. It's going to originate from the fibula, descend down, cross the ankle joint, cross the first MTP joint, and insert onto the distal phalanx of the great toe. Therefore, it also can assist with dorsiflexion of the ankle, but primarily its role is to dorsiflex or extend the first MTP. The last muscle we'll see in the anterior compartment is the variably present fibularis tertius, which arises from the fibula and inserts onto the dorsal surface of the base of the fifth metatarsal. Therefore, it can assist gently with dorsiflexion, but because it crosses and inserts onto the lateral foot, it can also assist with eversion, while the extensor hallucis longus and the tibialis anterior inserting on the medial side of the foot can assist with inversion. The fibularis tertius is present in about 90% of the population. The lateral compartment of the leg is very straightforward. There are two muscles, the fibularis brevis and longus, that both participate in eversion of the foot, or turning the sole of the foot out. They both attach to the fibula, as we can see in these two images, and their tendons course posterior to the lateral malleolus, which means that they both can contribute to plantar flexion of the ankle in addition to eversion. Here we see two different fractures of the base of the fifth metatarsal. The picture on the left is an avulsion or dancer's fracture. As you can see here, it's an avulsion fracture, meaning that it's the tuberosity of the fifth metatarsal that gets avulsed off the remaining part of the base of that fifth metatarsal. This is often due to a very strong contraction of the fibularis brevis muscle. Recall that the fibularis brevis attaches here to the tuberosity of the fifth metatarsal. The typical mechanism is when a dancer lands in a plantar flex position and there's a strong contraction of the fibularis brevis to help stabilize the ankle during this plantar flex position. The radiograph on the right is of a Jones fracture. Here we can see a fracture where the base meets the shaft of the fifth metatarsal. The typical mechanism here is during a cutting event on the field or on a court, where the foot is plantar flex and there's forceful inversion, and the resulting impact fractures the connection between the base and the shaft of the fifth metatarsal. Now that we've seen the two compartments, let's talk about the innervation for these compartments. Recall that the common fibular nerve that we saw in the popliteal fossa courses around the fibular head. Right after it courses around the fibular head, it splits into the superficial fibular nerve and the deep fibular nerve. The superficial fibular nerve serves the lateral compartment, and the deep fibular nerve serves the anterior compartment. So again, how many muscles does the superficial fibular nerve serve? Just those two muscles in the lateral compartment, the fibularis longus and brevis. How many muscles does the deep fibular nerve serve? Well, there's three muscles plus the variably present fibularis tertius, so 3 plus perhaps 1. As we look over here to these two slides, we can see that the superficial fibular nerve has a very large cutaneous distribution. So it's along the lateral leg and almost the entire dorsum of the foot, with the exception of the area, the first dorsal web space, or the area between the first toe and the second toe. We call this the flip-flop area. So here you can see this yellow area served by the deep fibular nerve. How does the deep fibular nerve get there? Well, as it's coursing down the anterior leg in the anterior compartment, it ends up going pretty deep to the retinacula, and it stays deep. It's already served the 3 plus 1 muscles in the anterior compartment, and then it works its way back superficially to serve this area between the first and second digits. Once again, here we see the superficial fibular nerve. It's innervated fibularis longus and brevis, and then it's split into several sub-branches to serve nearly the entire dorsum of the foot. A common orthopedic procedure is using a cast to set and properly heal a fracture, and it requires typically a 3-point cast mold. Leverage is important using this approach, and therefore bringing a cast as high up as possible is often desired, depending on the site and type of fracture. I've drawn in here the approximate location for the fibular head, and then the approximate location of the common fibular nerve before it branches into the deep fibular nerve serving the anterior compartment and the superficial fibular nerve serving the lateral compartment. If the course of the common fibular nerve is not taken into account when applying a short leg cast, the nerve can easily be lesioned. So question, what symptoms would you anticipate if a lesion to the common fibular nerve occurred? Well, we can now easily look downstream of the lesion, and we could figure out that if a lesion occurred here, both the deep and superficial fibular nerves would be affected. Therefore, the anterior compartment would be weak as well as the lateral compartment. This would result in a symptom called drop foot, where the person is unable to dorsiflex the foot when they are walking, and their foot would slap down against the ground. The patient would also have some sensory deficits here in the distribution of the deep fibular nerve, meaning in the flip-flop area between the first and second toes, as well as the distribution of the superficial fibular nerve, which would be the lateral leg and now the remaining dorsum of the foot. The blood supply for all three leg compartments come from the popliteal artery. We saw the popliteal artery in the popliteal fossa, i.e. the back of the knee. This popliteal artery will come down and it will split into several arteries. Let's take a look over here for a simple view. Again, this is the posterior side of the knee. Here's the popliteal artery and that popliteal fossa. The popliteal bifurcates or splits into an anterior and a posterior tibial artery. You can probably guess that the anterior tibial artery is going to serve the anterior compartment. So it's going to go through a gap in the interosseous membrane here to serve the anterior compartment. The posterior tibial artery will ultimately come down and serve the posterior compartment. And while it's doing that, it's going to give off a branch, the fibular artery, and you can guess that that's the artery that's going to serve the lateral compartment. Here we see the split of the posterior and the anterior tibial arteries. Posterior, again, continuing down. We're going to find that posterior tibial artery course medially, but stay posterior, at least posterior to this medial malleolus. So it's going to course between the medial malleolus and the calcaneus on that medial side. And here we see that fibular artery coming off that posterior tibial artery and coursing down. Now it's going to course down in the posterior compartment of the leg, but it's going to serve the lateral compartment by giving off these little perforating branches that are going to go over into that lateral compartment. The anterior tibial artery, once it's passed through that gap in the interosseous membrane, it courses down underneath the cover of tibialis anterior and it serves the anterior compartment. This vessel, after serving the anterior compartment, continues on in the foot. We can pick it up here on the right-hand side. Here is that anterior tibial artery. And then once it crosses the ankle joint, it turns into an artery called the dorsalis pedis artery, which is clinically very important because this is one of several arteries where we can find a pulse in the lower extremity. And when we're assessing circulation in the foot, we often turn to this dorsalis pedis artery to find a pulse to see how well circulation is getting diverted to the lower extremity. Let's go back to the picture on the left if we can make out this dorsalis pedis artery here in red. Note that it's just lateral to the extensor hallucis longus tendon. So one easy way to find dorsalis pedis, if you have a patient who's alert and can follow directions, is you have them pull up their big toe. When they pull up their big toe, the extensor hallucis longus tendon pops out, and you shift your fingers just lateral to that tendon up in this upper foot region to palpate the pulse. In this second part of a two-part series on the leg, we'll be discussing the posterior leg and the plantar surface of the foot. Here we can see the posterior musculature of a couple individuals. Can you guess who these folks might be? Yes, on the left we can see the muscles of Arnold Schwarzenegger, former actor and former governor of California. On the right, as you may have guessed, based on the shoe, this is Michael Jordan. So in this discussion, we'll be looking at this region, the posterior compartment of the leg. As you may recall, the fibular artery courses through this compartment but serves the lateral compartment. And here we see the posterior tibial artery and the tibial nerve, which courses with that posterior tibial artery, coursing between the superficial musculature and the deeper musculature of the posterior compartment. I just alluded to the idea that the posterior compartment has a superficial group of muscles and a deeper layer or deep group of muscles. Here we can see the most superficial and recognizable muscle, the gastrocnemius. The gastrocnemius has two heads. It has a medial head and a lateral head. Note that the gastrocnemius is going to cross the knee joint. Therefore, it can act at the knee joint. So it can flex the knee. And of course, it's going to cross down to insert onto the foot. So it can also plantar flex the ankle. Proximally, it's going to attach here at the medial and lateral condyles of the femur. Distally, it's going to attach here on the calcaneus. Through its long tendon, the tendon of the gastrocnemius, as it merges with another tendon of the soleus to form the calcaneal or Achilles tendon. Here we can see the merger of the two tendons forming the calcaneal tendon, up here being the tendon of the gastroc, and down here, very small, being the tendon of soleus muscle. It's hard to appreciate here that the calcaneal tendon has a broad attachment point on the calcaneus proper. Note the existence of a few bursa, one superficially to allow the skin to rub over the underlying bone, and one between the tendon and the bone, again to allow for some movement. Underlying the gastrocnemius is the soleus muscle, which attaches from both the fibula and on the tibia. The soleus muscle is responsible for assisting the gastrocnemius in plantar flexion of the foot at the ankle joint. It's important to note that the soleus is the workhorse of these two muscles. The soleus is used on a day-to-day basis during normal gait. The gastrocnemius, in contrast, is used when there is high load demand or when there is a need for a large amount of force or torque, such as during a sprinting event or a jumping event. Sandwiched between the two muscles is a long tendon of the plantaris muscle. This tendon is considered the freshman nerve, coined because freshmen or first-year medical students often confuse this tendon for a nerve in the gross anatomy lab. Arising from the distal lateral femur down to the calcaneus, this muscle can serve as a very weak plantar flexor. We shouldn't overestimate its function, however. It's considered a vestigial muscle, meaning it has a very insignificant function. This muscle can hypertrophy, however, in those who jump a lot, so perhaps it does contribute to the force of the gastrocnemius and a little bit of the soleus during these high load events. Two injuries of the calcaneal tendon are tendinitis and tendon rupture. Tendinitis is most commonly seen in amateur runners in their 30s and 40s who are upping their mileage. On clinical exam, the patient may present with very little pain, at least at rest, but they're often tender to palpation in the area of injury. A calcaneal tendon rupture is a severe acute muscular problem of the leg. These injuries usually occur in an amateur athlete, a weekend warrior of sorts, who hears and feels a pop or a snap when they're going to plant their limb to change direction. This injury is 5 times more likely to occur in men who are 30 to 40 years of age. Treatment for such an injury includes either conservative management by immobilizing using a cast or a boot. Interestingly, the end result for the surgical procedure or the immobilization are generally the same. This is even true if there's a large gap between the two ends of the tendon, where the tendon will track itself back to the other end remarkably well. By cutting through the Achilles tendon and removing all those superficial muscles which inserted into that Achilles tendon, we can now reveal the deep group of muscles within the posterior compartment. Note that there are 4 deep muscles. The proximal most muscle is the popliteus muscle. The popliteus muscle attaches from the medial tibia and extends up to the lateral femur. Here we can see the tendon of the popliteus slipping up underneath the LCL ligament to attach onto that lateral condyle. In this image, we can see a little bit better the medial tibia extending up to the lateral femur once again. This muscle has a peculiar function. As it's attached here and here, it's going to provide a rotational pull on one bone relative to the other bone. Typically in standing, when we're in a locked position here in between the tibiofemoral joint, to unlock the knee, the popliteus contracts and pulls the femur laterally with respect to a stable tibia. So you can see this attachment point, it will pull the lateral side of the femur posteriorly. That's going to laterally rotate the entire femur with respect to that tibia. Conversely, when one is going from flexion into full extension, the popliteus will help smooth that transition so that the knee doesn't snap into place. So the popliteus will have what's called an eccentric contraction, or it will lengthen to allow the femur to rotate medially with respect to that stable tibia. The three other muscles of the deep compartment are the tibialis posterior, the flexor digitorum longus, and the flexor hallucis longus. Note all three of these are going to project distally and medially to go through this region called the tarsal tunnel that we'll see more in a minute, posterior to the medial malleolus. Therefore, in addition to their primary actions, which we'll discuss in a minute, all three of these muscles can contribute to foot inversion. The tibialis posterior attaches from the tibia, the fibula, and the interosseous membrane. It descends down the leg, again goes medially, to attach broadly onto several bones. Note its attachment onto the navicular in this region, the first cuneiform, other cuneiforms, but it also reaches all the way across to grab the cuboid bone. Because it traverses the ankle joint medial and it has a broad attachment site to these tarsals, it's a primary stabilizer for the medial arch of the foot. The flexor digitorum longus muscle is adherent to the posterior shaft of the tibia, and like tibialis posterior, it sends its tendon around the medial malleolus posterior to it on its course to the lateral 4 digits. Therefore, it's able to help with plantar flexion of the ankle, help with inversion of the ankle, and it's also able to flex the 4 digits. The flexor hallucis longus muscle originates from the fibula, descends down again medially, helps to plantar flex the ankle and invert the ankle, and then inserts onto the distal phalanx of the great toe and is able to therefore flex the great toe. Here we can see a better picture of this tarsal tunnel. We have the medial malleolus and the calcaneus, and then we have this item called the flexor retinaculum that spans between the two bones. Recall on the anterior side, or on the dorsum of the foot, we saw the extensor retinaculum. So this space between the medial malleolus, the remaining tibia, and the calcaneus, and the flexor retinaculum is called the tarsal tunnel. That's this area occupied by the blue arrow. Through this tarsal tunnel runs a few structures. We can identify each of these structures by applying a mnemonic. The mnemonic would be the Tom, Dick, and now Harry, or if we want to include the vein in here, it would be Tom, Dick, and very nervous Harry. So Tom would be the tendon of tibialis posterior. Dick would be the tendon of flexor digitorum longus. The A would be the posterior tibial artery. The N would be tibial nerve. And the H would be the tendon of flexor hallucis longus. So that usually helps people get through this tarsal tunnel. Recall in the medial compartment I had mentioned that the dorsalis pedis is a nice spot to find a pulse on the anterior or dorsum side of the foot. Posteriorly, we can find a pulse here in the tarsal tunnel with the posterior tibial artery, palpated roughly halfway the distance between the medial malleolus and the palpable calcaneus. On the next slide, we're going to see the course of the tibial nerve through the posterior compartment. But while we're here on this slide, I'd like to point out that the tibial nerve, after it goes through the tarsal tunnels, is going to split. Here we're going to see the medial plantar nerve and a lateral plantar nerve. Let's just keep that in mind as we go through the next couple slides. Here we can see the tibial nerve coursing down the posterior leg. Recall that it originates from the much larger sciatic nerve, and as that sciatic nerve descends down the thigh, it gives off the common fibular nerve. Here's the old terminology of common peroneal. We know it as the common fibular. It gives off that common fibular nerve, and essentially it continues on as that tibial nerve. As it descends down, again goes to this medial side of the ankle. Here we can pick that up as an illustration of splitting into that medial plantar nerve and the lateral plantar nerve. It's important to know that all the intrinsic muscles of the sole of the foot, and as you can see there are many of them just like we saw in the hand, they're all innervated by these medial and lateral plantar nerves. The medial plantar nerve being the equivalent of the median nerve in the hand, and the lateral plantar nerve being the equivalent of the ulnar nerve in the hand. That said, you will not be responsible for knowing the intrinsic muscles of the foot. More on that in a few slides from now. What I would like you to know is the innervation for the bottom of the foot, which is very important because this is the part of the body that interacts directly with the ground. It's also very important to know from a diagnostic point of view when we're looking at spinal cord injury or peripheral nerve lesions. So here we can see 4 nerves that serve the sole of the foot. Before the tibial nerve splits into the medial and lateral plantar nerve, it does send off some cutaneous branches to the back of the leg, as we can see here, but then also to the heel via a branch called the calcaneal branch, which you don't need to specifically know. It then splits into the medial and lateral plantar nerve, with the medial plantar nerve serving much of the medial half of the foot, lateral plantar nerve serving the lateral third of the foot. The saphenous nerve, recall, innervates the anterior medial part of the leg and then extends into the medial foot. We can see that continuation into the sole of the foot. Now this doesn't occur in all individuals, but in many individuals the medial arch of the foot is innervated by the saphenous nerve. And then laterally we see the sural nerve similarly extending down in the lateral leg and catching the lateral side of the foot. So that covers the peripheral nerve distribution. But also notice we have some spinal levels listed here, and those are important to know. What I'd really like you to know are these spinal levels listed here. So the great toe is generally innervated by L4. So that would be the dermatomal level or the spinal level for the great toe. That's important for a clinical exam. The second and third toes are generally L5, and the pinky toe is generally S1. That goes for the dorsum of the foot as well as the plantar surface of the foot. So just like in the hand where the thumb was C6, the middle or the index and middle finger were C7, and the pinky is C8, here we can go from medial to lateral and go from L4, L5, and S1. A common issue in the leg is shin splints. Usually a complaint with a new runner or someone who has recently increased mileage. The pain can be just medial to the tibial crest or just lateral. In this picture, the letter A is suggesting the medial location for shin splints. This is also known as medial tibial stress syndrome. This condition is a bit of an enigma. It's thought to either affect flexor digitorum longus or tibialis posterior. Symptoms anterolaterally are thought to be associated with the tibialis anterior muscle in the anterior compartment, with small tears in the periosteum overlying the shaft of the tibia. It's proposed that edema and muscle tendon inflammation accumulates in the compartment, and this increased compartmental pressure reduces blood flow to the actual muscles, making them painful and tender to pressure. That said, stress fractures could also be the cause of pain in this region. They are often hard to see on radiographs and are often missed diagnostically. Fortunately, the treatment for both conditions is rest, or at least a reduction in the stressful activity. We saw that the posterior tibial artery courses through the tarsal tunnel. It splits into a lateral plantar artery and a medial plantar artery, both of which follow the lateral medial plantar nerves. Overlying the muscles and neurovasculature of the plantar foot is the plantar aponeurosis. This is a thickening of the deep fascia in the sole of the foot that extends from the medial calcaneal tuberosity down and inserts onto the metatarsal heads of all 5 digits as well as the proximal phalanges. The plantar aponeurosis helps to support the arch of the foot and can become inflamed from high impact activities or from prolonged standing or an increase in mileage during running. Patients tend to complain of pain in the heel posteriorly close to the calcaneus, but it can often radiate anteriorly into the mid-substance of the heel. Classic plantar fasciitis is when a patient feels pain first thing in the morning upon rising out of the bed or after sitting for a while, goes to stand up and feels a sharp stabbing pain, sometimes a dull ache in the posterior heel. As you might imagine, if the plantar fascia is inflamed, dorsiflexion, or pulling the foot up, and extending the toes will increase the patient's symptom. Note here the transition from the first metatarsal to the first proximal phalanx. It's a relatively straight line. A bunion is a progressive deformity characterized by the medial deviation of the first metatarsal and a lateral deviation of the proximal phalanx. Note, however, it's not just a medial deviation of this metatarsal, it's also internal or medial rotation of the actual bone with the attached sesamoid bone, which places the sesamoid bone in between the first metatarsal head and the second metatarsal head. Recall that the deep fibular nerve has descended down the anterior leg, served the anterior compartment, and in the foot stays relatively deep until about this spot here, and then it becomes relatively superficial to innervate the first dorsal web space. Well, now we have a sesamoid bone that has rotated inward between the first and second metatarsal heads to now compress this deep fibular nerve as it's progressing towards the toes. As you might imagine, this produces a very painful situation and also some numbness and tingling downstream. And that concludes this second of 2 videos on the leg. Thank you for your attention, and please let me know if you have any questions or comments.